Now, everybody wants to get to this question, get to the answer of this question. What if we could prevent OSA? And as orthodontists, we really want the answer to this question. What if we could develop the airway? Can we? And I think there's been a lot of evidence proposed over the last couple of days that we have some influence on this. We affect how jaws grow, we affect how teeth erupt, we can affect how tongues live. All of those things can, down the line, affect the airway health. And so I think we have the ability to have an influence. This is a maxillary palatal expansion study that's looking at nasal airway volume changes. And just like Dr. Liu and Dr. Yoon were talking about, increasing that nasal volume, everybody went up with the expander. Nobody had a decrease. The more air, the more velocity going through that nose, the less collapsible your tube is going to be. 15% increase with expansion alone. So if you're an orthodontist and all you do is expansion, you're actually helping nasal volume. So you're helping airways whether you know it or not. Does that affect how that airway grows over time? Perhaps. From an orthodontic perspective, we have to think about the structures that involve us, which again, we're tooth focused, of course. But this paper, and Rebecca Backow in her beautiful keynote yesterday mentioned this paper, the Minor study. I'm going to break it down in super simple terms. Here's what this study did. It was a cone beam CT study. They looked at the coronal slice of the jaws at the first molars. And they divided the sample up into 5 categories. Normal control on the far left, unilateral crossbites, bilateral crossbites, superior convergent, which we don't know very much about in orthodontics, and then finally on the far right, inferior convergent, which I don't see very often. It's the superior convergent that's the tricky one for us. That's where the maxillary molars are leaning out towards the mandible and the mandibular molars are leaning in. Now here's what the academicians did on this study. They measured the skeletal width, not the dental, the skeletal width at the maxilla and the mandible at that first molar coronal site. Keep in mind, clinically, and this is how I was trained, when I do a clinical exam, if I'm looking at molars, maxillary narrowness meant crossbites. If there were not crossbites, I did not identify maxillary discrepancies, maxillary narrowness. I didn't see it. And on my study models, if there wasn't a crossbite, I didn't see it. Normal controls, no crossbites, and superior convergent cases look the same. They looked the same to me for the first 10 years of my career. I didn't see anything wrong with them. The roots and the axial inclination in the coronal slice are very important. And to me, the transverse dimension, since I've been in 3-dimensional orthodontics, the transverse dimension has become the most important dimension to me as an orthodontist. Here's what the study revealed. The normal controls, the maxillary skeleton on the lingual, was about 1 millimeter smaller than the mandible. That's the normal control. But look at the superior convergent cases. No crossbites. The skeletal discrepancy was greater than that of unilateral crossbites. And for most of us as orthodontists, we'd treat unilateral crossbites all day, but we'd leave the superior convergent alone. And this took a lot of retraining in our community for me to tell the pediatric dentists, don't just wait for a crossbite. Send me everyone at 7 and let me measure. Because we're going to find a lot of superior convergence. And this is the take-home message from the paper. patients without crossbites can have significant discrepancies that might warrant treatment. And this happens a lot. And it affects airway when you treat it. Now, if your only take home from all of the airway content is identifying these massive obstructors, tonsils and adenoids, you will have a win-win situation when you get back to the office. Because if you identify a Maddie in your office, you will change those parents' lives. Guarantee it. So if all you're doing is screening for tonsils and adenoids, doing snore checks, talking to the mom, you're going to change some lives. Now, what happens when you get involved with either TNAs, tonsillectomies and adenoidectomies, and expansion? This study sums it up very well. What they did is they had a group of patients, all of whom needed a tonsillectomy, adenoidectomy, and expansion. And they divided the sample into two halves. One group would get the TNA first, expansion second, and the second group would get that flipped. Expansion first, then the TNA. They did AHI, they did sleep studies on all the patients at every time point, beginning, after the first procedure, and at the end. And here's what they found. The good news is all the patients improved, which is awesome. So on average, they were able to get AHIs of 12 down to less than 1, which is great. AHI for children should be 0. And RDI, which is a slightly more sensitive test of how well you're sleeping, RDI went from 21 all the way down to 1.6. That's a big improvement. Now, if you're just doing expansion and you're not addressing tonsils and adenoids, what's your effect on AHI? And so I was interested in this group that had orthodontics first. And you'll notice that the AHI and RDI decrease with just expansion. And that's great, because even if you're missing the tonsils and adenoids, you're still improving AHI by 51%. If you just do the TNA and you're not doing expansion, you're improving it by 55%. Now, what happens in the real world is those two procedures often live in different doctor worlds. When you put them together, it becomes very effective. 91% decrease in AHI with expansion and TNAs. Now, here's what we do commonly in our practice. Two-phase treatment is very common. Usually, on average, it starts around age 9, 9.5. Phase 2 begins at 12, and then we're finished and out by 13.5. If you think back to the Schendell study, the average of the MCA, that's depicted here on the top bar. So remember, it's 10 times their age. So our average of phase 1, 95. This is an in-house study of 26 consecutively treated expansion patients. No TNAs, just expansion. So what you're seeing on the top is what we would expect those patients to be in terms of MCA, if we listen to the Schendell data. The average of this sample in my practice was 77, and the mean was 70. For those who know statistics, if the mean is close to the average, it means you have a relatively normal curve. Here's what happened to MCA after phase 1. The average MCA already surpassed what we would have expected from just normal growth. And the median fell a little bit. There are some laggers. But here's what happened after phase 2. This is 2.5 times change in MCA compared to what we would expect from the normal progression from Schendell. Now, I'm not saying this is curing anything. This is simply changing anatomy in a way that makes me open my eyes.